John, can you invite the speakers to come to the podium, please? Oh, this was a
if
joke.
any speaker did not hear that, could you come to the podium, please?
And to the audience, if you have burning questions, then you may have some sheet of papers where you can write your question, and we'll do our best to answer your questions. But there is
Can they? No.
So if no burning questions from the audience, then we can start a panel discussion. Well, you are not in the audience.
He was in the audience, technically.
Well, I was in the audience until very recently. I've got a question for John. And the fascinating data in relation to obesity, do you think there's a different mechanism for the onset of atrial fibrillation in those with marked obesity and perhaps changes in wall stress in the ventricle?
Certainly there's a very great interest in the mechanism of atrial fibrillation in patients who are obese. It's been very well demonstrated that quite apart from these indirect mechanisms such as associated coronary disease, hypertension, etc., that fat infiltration in the subepicardium and involving the atrial myocardium is a highly arrhythmogenic feature. This has been very well demonstrated by Stefan Hatem in Paris, and it seems to be a quite specific mechanism in obese patients. So presumably it also has a quite specific method of dealing with it, but we don't know what that is yet.
Okay, let's move on to Lorenzo, just to introduce this discussion on treating the whole patient.
Thank you very much, Mr. Chairman, dear colleagues. This is going to be a two-persons moderation. Here our disclosure, mine and Professor Verheugt disclosure. My next disclosure is that I am obese. My body mass index is 36. So I have to survive another 20 years to get to the obesity paradox, and I hope I will do that. But if I have a heart attack now, I know I'm in the right place anyway. So I have basically three main questions or points to spark the discussion. The number one is the competing risk. It's basically a question that was sparked by the presentation of Keith Fox and of Samuel Goldhaber. So apparently there are a lower or higher prevalence in men of patients that had an acute coronary syndrome, while during the follow-up, women are at a higher risk of developing a stroke. And the question is that because we lost the bad risk men that developed an ACS before being able to develop AF and then later a stroke? Is there some mechanism like that? I'd like to have your opinion.
Lorenzo, I think that's a very important point, and you're talking about survival bias that may be because of early deaths, and that may be part of the mechanism. But you've also seen some interesting data from others in this symposium about the risks in women versus men. And so maybe not all of it's explained by that.
Samuel, do you have any opinion?
I think this is one of the great unanswered questions of why women have a 30% higher stroke rate than men, and that's after multivariate adjustment, and there are probably more factors for us to discover to really enhance our understanding of this. And I do think also as we advance in our use of biomarkers that we'll have in the future better predictive measures, especially for women, so we can have early intervention.
Thank you. If I can have the slide. So my next, I'm an epidemiologist, and I do health services research for planning purposes. And What struck me, again, in this presentation is the difference that was emerging, in my opinion, but I want to hear the panel, between complication and complexity. Complication has to do with a disease that may be complicated, and a complexity has to do with a patient. Just to make a classical example, this is complicated, extremely complicated, but is a system that moves in patterned ways. If you stop one of these, if you take away one of these rubies, then what is downward will not work. And this is a human being, which is a complex system. It's not, it may be complicated, but it's complex, in which if you touch one part, some other parts of the systems will react in known pattern and much more difficult to predict ways, and the outcomes is known pattern. Another example is typically done as sending someone to the moon. It's very complicated, but once you do it once, you can replicate it forever, more or less, as long as you have money enough and you are willing to do. And complexity is raising a child, which, you know, if you did once correctly, it doesn't mean that the next will be, again, what you hope it will be. So my question to the panel is, again, do you think that we are speaking about a complicated condition or a complex patient?
Well, perhaps I'll start. I'm pretty sure we're dealing with complexity. Obviously, the human body is complicated, but when we manage patients, there are far more factors involved than we can simply identify. And therefore, even if we look at very similar patients and we treat them in very similar ways, we can have very divergent results. So that's like bringing up your children. And I'm sure that we have a very complex problem here, because we have to try and sort out so many different risk factors, so many different mechanisms by which atrial fibrillation occurs. We have to distinguish, for example, between the triggering factors of atrial fibrillation and the factors that sustain atrial fibrillation. We have to consider the management of the underlying disease that tends to make atrial fibrillation more common. But in addition to that, we have so many other complex factors that contribute to all the risks of atrial fibrillations, which are related to the comorbidities, for example, and also to factors that are far beyond our comprehension at the moment. So I have no doubt that we're dealing with a highly complex situation, and complication simply doesn't do it justice.
But let me, John, pursue that slightly. Do you think that the approach we have taken to understanding risk in these patients has slightly stifled our ability to integrate all the knowledge we're developing in cardiovascular disease and drive programs of intervention that look at the totality of risk? Because there tends to be a view taken that targeting one part of that risk spectrum could achieve an outcome, whereas I think the data we're starting to see suggests that we need to be much more holistic in our approach.
I completely agree with that conclusion, because obviously we learn a simple mantra that patients with atrial fibrillation need rate control and thromboembolic protection. That is far too simplistic. It's very important, of course, and it's something that we should all bear in mind and make sure that that is done. But it is not sufficient, because we have to deal with all the factors that promote the disease, promote its progression, increase its risk, and complicate its management with various therapeutic strategies. So just concentrating on risk stratification to decide yay or nay with regard to anticoagulants is nothing like good enough.
Sam?
So one of the great challenges we have is getting the patient and the family to buy into our prescription for risk factor modification. And that includes things like stopping cigarette smoking, exercise, good nutrition. In addition, in the majority of cases, taking an indefinite duration anticoagulant. And so this just adds into the complex equation.
Yes.
Sam also commented on some of the biomarkers, and I think this is really fascinating because here's the hint that we're dealing with systemic disorders that are having a back influence on the heart, whether it's NT-proBNP or troponin or markers of renal dysfunction. These are highly predictive of adverse outcome, and I think that this is the signal to us to look systemically.
Right, and I think the biomarkers can sometimes raise the alarm bells, whereas a CHA2DS2-VASc score of 2 may not.
Lorenzo, shall we come back to you in your further discussion, because we've got to hear from Professor Verheugt as well, and then we can have some questions. If there are, please, there are microphones here at the front. Do come and to a microphone and raise your hand. Let us know if you'd like to make an intervention.
Yes, thank you. Well, the next point that I was trying to raise was integrated care versus silo care, but I guess that you have already responded to it. And this is a very recent paper in which actually patients with new AFib were followed up for two things, well, for a number of things, but then the analysis based on CHF onset and then the CHF and death, and how is it possible to manage these patients. And I'll go very briefly to this slide. So if concomitant conditions are not by any reason, for any reason, controlled, it's taken as a reference, and if one of these conditions, which is systolic blood pressure, cutoff of 120, BMI below 30, no diabetes and no smoking, are actually managed or are not present, you can see an 86% reduction in the hazard of developing HF and consequent death. So it looks like that really integrated and coordinated care for a complex system. It's complex biologically, and it's also complex behaviorally. If the patients that we have talked about today are taking all the medications that are written in guidelines, probably they would be taking 10 to 12 medications a day, and that behaviorally is quite complex. So integrated care is likely to be the way forward, and I just leave it with a couple of quotations of people that know a little bit about systems. And this guy says that actually the human body is a complex system. It's the more complex ever created, and the more we know it, the more we realize that it's complex. And it's not a good idea to find a simple solution for a complex system, because you are likely to find a wrong solution, and this is a Nobel laureate for economics. Now with that, I leave the floor to Professor Freek Verheugt, who supposedly will bring you back to cardiology and less to philosophy. Thank you.
Now, I would like to focus more on the treatment of patients with atrial fibrillation, and especially the antithrombotic therapy, because that's where this symposium is mainly about. And there are some good news figures, as we have seen, but also very bad news figures. Let me start with the good news, and I think this is maybe the most important slide of today. If we look at the propagation of NOACs in the 5 cohorts we studied in Garfield, from 2010 to 2016, a huge uptake of NOACs, and in fact increasing use of oral anticoagulation in patients with atrial fibrillation, and that's the way how we can protect our patients against stroke. So this is again the very good news. So I don't think there is many comment on that by the panel, but look at this, and this is the bad news. We see here a slide by Dr. Goldhaber showing that the majority of endpoints in the patient with AFib in our registry is mortality, and much less is stroke, and even less is bleeding. And we can prevent stroke very effectively with anticoagulation. We may increase bleeding a little bit, but what can we do about mortality? We should do very different things than anticoagulate we should do treatment of hypertension, of comorbidities. And I heard a lot by the panel about how to do that, but maybe there are more things than only treating or preventing heart failure or preventing coronary disease. And I would like to hear from the panel if they have more ideas about preventing mortality than stroke prevention.
Who would like to start? Sinya.
Sinya, yes.
We have another registry of, patient with atherosclerosis we have previously conducted. And we realize atrial fibrillation is a kind of sign for cardiovascular death. So that, this is the frequent cause, most frequent event in atrial fibrillation. So what can we do? Maybe we can reduce heart failure death by using guideline established therapy like ACE, ARB, or beta blockade. I think that kind of drug is still not largely used. And maybe, SGLT2 inhibitor for prevention of heart failure may be also suitable for patients with atrial fibrillation.
And maybe by omitting digoxin. That's another issue we see now in the literature, the harm of digoxin in heart failure patients who have AFib. Is that also an option?
Well, I mean, I think that's a very important point. I was going to say to Keith, do we do enough about understanding what interventions in contemporary practice should be retained as part of a program of integrated care, as opposed to those that should be replaced and supplemented to ensure that contemporary knowledge drives the best clinical outcomes for patients with complex diseases?
Yeah. I think Lorenzo touched on this, and it's the issue about silo thinking, because we focused on managing the atrial fibrillation, and as we've heard, clearly AF is a risk factor for stroke, but it's a risk marker for other systemic conditions. And I'm worried that we need to be able to understand some of the underlying mechanisms associated with perhaps renal disease and vascular disease. And I think increasingly we're going to see AF as a manifestation of complex vascular disease, not just a phenomenon in the heart.
Yeah, please.
Well, Freek, to answer your questions on how we can improve the outcome of our patients, I have a quite clear answer. I will refer to this in my concluding remarks. If you look at the data that we have collected in GARFIELD and look particularly at the drugs that are prescribed in these conditions that affect more the outcome, namely congestive heart failure, chronic kidney disease, and coronary artery disease. If you look at the drugs prescribed for these three specific diseases, we can state that at least 50% of patients with this kind of disease are undertreated, not optimally treated. If you look at the number of drugs, guidelines recommended drugs prescribed in this patient. Just an example, coronary artery disease. Patients should receive at least up to 4 drugs. More than 50% of patients receive only 2. And these 2 are aspirin, added sometimes statin, sometimes ACE inhibitor, sometimes beta blocker. 50% of the patients are undertreated. What is true for coronary artery disease, it's also true for congestive heart failure. It's more delicate to know for chronic kidney disease where the rate of prescription of ARBs or ACE inhibitors is quite low, but we know that we have to be careful with chronic kidney disease and prescription of these drugs. And these drugs may also be prescribed for other comorbidities like hypertension. But clearly for congestive heart failure and coronary artery disease, patients are usually undertreated. And the worst situation, for example, patient with class 4 in class 4 of the New York Heart Association are really poorly treated, both as regards anticoagulation, but also drugs needed for the disease. Might be linked to what I call the polypill syndrome. You don't, maybe the clinicians do not dare adding yet another drug on top of already 4 or 5 or 6.
I think an important point is that because this is a global registry, we're able to look at whether there were differences in patterns of practice throughout the world, and there's not a lot of difference. I think that we have to look throughout the whole world about making sure that guidelines are followed.
Yes.
Sam.
So I'd like to follow up on what you've mentioned, Keith, about patients who have ACS history getting only low-dose aspirin in the GARFIELD registry with 50,000 plus patients. We did an audit at Brigham and Women's Hospital in a registry of 5,000 patients with atrial fibrillation, and we found the same thing. So I'm wondering, are we exaggerating in certain patient subgroups the risk of combining low-dose aspirin plus anticoagulation, and is the pendulum swinging too far away from low-dose aspirin plus an anticoagulant? What's your feeling about the combo of antiplatelet therapy and anticoagulation in coronary artery disease patients, for example?
Well, I have to declare an interest because I'm involved in the design and conduct of the COMPASS trial, and you've put your finger on a critical interaction, because thrombin is one of the most potent stimuli for platelet activation, and in turn, platelets have a thrombin receptor. So the old idea that you just got to treat these independently is wrong. And we're going to see tomorrow what is the impact of either a single anticoagulant or a much reduced dose of anticoagulant, a quarter, plus one antiplatelet. And I think this is going to have a very interesting change in the way that we manage our patients.
So the prescription really gets back to the adage of the right dose of the right drug for the right patient, and that really pertains to our atrial fibrillation patients and all of our cardiovascular medicine patients.
Yes, yes.
Very much so.
May I get the next slide, please? Because I would like to continue with the bad news. When we look at the heart failure patient, this slide was shown by Graham Turpey about the patients in Garfield with heart failure, and look at their treatment. The treatment with anticoagulation is much less the worse the New York Heart Association class is. And maybe here we see also a risk for mortality if patients have a lower protection against stroke, which I think is a disturbing thing, and I would not see the cause of that. Why do we undertreat our severe or hospitalized patients with heart failure with less protection against stroke? I have no idea. Graham, can you explain that to me?
Well, I don't think we have an explanation for that. It's clear that there is a reduced use of anticoagulants in the more severe patients. It might be that the clinicians are more concerned about the bleeding risk. Many of these patients will have hepatic congestion and perhaps have some minor coagulopathy, and that might influence the utilization of anticoagulation.
Thank you. And then, of course, the issue, we discussed that now more or less more extensively, the problems that patients have a history of ACS, and this was a slide by Keith Fox showing that when patients do have ACS in their history, there's much more antiplatelet therapy, but not less stroke prevention. I think that is the good news, but this is, of course, the bad news, because this will lead to more bleeding, and especially when you look at the patient with the highest stroke risk. Here you see the problem that there is more antiplatelet drugs, so more bleeding, and less protection protection against stroke. So these patients are not very well off because they had a history of ACS and they are less protected against stroke and are more exposed to more bleeding. And this was, I will skip this one. This was as shown by Keith. The patients who had a history of ACS have a worse outcome almost on all points. And that's again what was pointed out already by Jean-Pierre Bassan. We should maybe focus on these coronary patients. We should treat them better than we do currently when they have concomitant atrial fibrillation. They should have ischemia detection more often. They should maybe have more PCI or coronary surgery than we do currently because they have only AFib. So that is also a point for discussion to me. And that will be my last slide. Thank you.